Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Bioethical Aspects of Gender-Affirming Care in Youth, presented by Dr. Burgundy Johnson. My name is Coffee Dixon, and I'll be hosting the session today. I'll cover a few housekeeping announcements before we get started. The webinar will be recorded and made available for viewing on our YouTube channel, but please allow 1 to 2 business days for the recording to be made available. The link will be shared in the follow-up email after this session. Following the presentation, we'll have time for questions, so please feel free to put your questions in the Q&A in the webinar toolbar, and we'll cover as many questions as time allows. In the chat section, I will attach instructions on how to claim continuing education credit. And I will also share this information in the follow-up email after the session. So without further delay, it's my pleasure to introduce our presenter today, Dr. Burgundy Johnson. Dr. Johnson is currently the Division Lead of Child and Adolescent Psychiatry at Carle BroMenn Medical Center, as well as Adjunct Clinical Assistant Professor in Child Psychiatry at the University of Iowa Hospitals and Clinics. She did her Child Psychiatry Fellowship and General Psychiatry Residency at the University of Iowa Hospitals and Clinics. Her interests are community psychiatry, therapeutic approaches, and early childhood mental health. She lives in Iowa City with her husband, 2 sons, and 2 cats. So welcome, Dr. Johnson. I'll turn it over to you.
Thank you. All right, can you hear me okay?
Yes, you sound great.
You can see my presentation.
Yes, I can.
Great. Okay, perfect. So we'll get started. Thank you all for coming today. So like Coffee said, we're going to be getting into the bioethical aspects of gender-affirming care in youth. I have no disclosures to make, except for one disclosure, which is that we're not going to be talking about the legal issues or legislation. We can touch on it, but this is not meant to be approaching the political aspects, even though that's important. We're going to be talking more about just the basics of gender affirming care, what the research says, and looking at evidence-based care. It is a fairly basic talk, like a broad talk on things. So hopefully it helps people with some things, but if you already know a ton about this topic, then it might be boring. It's my 2 cents. I certainly learned something writing it. We're going to be going over the research regarding mental health and gender issues. We're going to assess and apply medical ethical principles to gender affirming care in youth. We're going to learn ways to navigate conversations about gender with youth and their families. Again, I wanted to touch on, I'm not going to go into the political stuff, but I do want to let you know that there have been many political changes, legal changes, which makes this a little bit more complicated. Of course, from all great research, the best place to go is Wikipedia. That's a joke, but you can see here that there's just been a lot of changes even within the past couple of months within the legal system in Iowa and how we approach gender affirming care. Specifically, what applies today for you guys to know is that in March 2023, the government in Iowa banned the provision to provide gender affirming care to transgender individuals who are minors in Iowa. Technically, they can still get care for 180 more days, but otherwise, right now, it ends up becoming illegal. So you can see there's also things about bathroom bills. There are a lot of other bills going on. You can see at the bottom here, I just put translegislation.com bills. You can see all the things that are in progress and what is already available. I put in Iowa specifically, but they have it for all the states. All right, we're going to start with the research. And again, I want to use the reason I put a compass here is I see the research as sort of my beacon when I'm talking about this stuff. Clearly, there are complex issues to navigate. There are very heated opinions. It's a complicated topic. However, at least for me, I can't always tell you what to say in a conversation with an individual. I think each care needs to be individualized, each person. But I will say for me, when I'm starting to be like, ooh, what should I say? What should I not say? I go back to what the research says. So I try and practice evidence-based medicine no matter what. And that sort of like, that points me to what I should and should not talk about. Now, when we are talking about gender issues, we're talking specifically in this case, primarily about gender identity, or excuse me, gender dysphoria. So gender dysphoria was the term we came out with in the DSM-5. Prior to that, it was gender identity disorder. The reason that we changed it was to put more emphasis on the actual distress that went along with feeling that someone is in the wrong body. We felt that gender identity disorder was more pathologizing of the individual, so that language was updated. These are our criteria. Sorry about the bad slide, but they're very broad criteria for gender dysphoria. But I do think it tends to cover the diagnosis, to be honest. So you can see here, it needs to be the symptoms need to go on for 6 months or more. And you have to have at least two of the following symptoms. So, for example, a strong desire to be of the other gender, a strong desire to be treated as the other gender, and then other things that are often associated, that I often see as well, a strong desire to be rid of one's primary and or secondary sex characteristics and things like that. So you just need two of these. And then the fact that it causes significant distress or impairment within their lives. So we're going to talk about gender dysphoria and the research a little bit. And again, there's so much research coming out. There's so many things we can talk about. This is a very broad topic squished into a little hour. And I do want to have time to discuss at the end. But these are some important things I think we should all know as medical professionals or people, working with kids. So what's something that we know about the development of gender dysphoria? Well, most experts agree that kids are aware of their own gender by around age 3, which I think is pretty interesting. Gender is a social construct, but it is so ingrained in our society and our cultures, how we approach boys and girls and other genders, depending on what culture you're in. Kids know what they are usually by the age of 3. Now, can they know if they have dysphoria at that age? Technically, yes. Do they have to? No. Everything is a spectrum. So they usually know what they are, what they're supposed to be, often, but it doesn't necessarily mean that they have to know, okay, I'm definitely a boy in a girl's body or vice versa. But they can. So one thing we have to talk about whenever we're talking about the development of gender dysphoria is this concept of persisters and desisters. And these terms are sort of, they've been evolving over time, but the way we generally use them as persisters are people who have gender dysphoria and continue to have gender dysphoria, versus desisters are people who have gender dysphoria and then ultimately end up identifying as their assigned birth gender. Some people say natal gender, assigned birth gender. There are many terms out there, so I'm going to use all of them. But what I will say is that for the majority, they found is most kids do end up identifying as their assigned gender. Now, there's still a significant proportion that don't, so who end up being persisters. And I think in the studies, they said it was a pretty big range. It was like 2 to 28%. So it was the minority, but still pretty large. Now, this is based on a couple of studies that went over decades that we have in child psychiatry. And I'm glad we have them, but of course, like with everything, there are limitations. For example, if a child was beginning to desist, if they were beginning to identify with their assigned birth gender, and then they fell out of the study, they were assigned as desisters. So who knows, maybe they went on years later to end up being, to identifying that they still had gender dysphoria, but that wasn't captured here. Still, it's good we have some studies. And what these studies help us figure out is there are some characteristics of people who tend to persist versus desist. Now, this isn't a one size fits all. Of course, I say these factors, these are things for you to look at, but you always have to keep in mind the person in front of you. Each person is different. So some things that are associated with persistence are early age of onset. Doesn't have to be, but early age of onset, the intensity of the dysphoria, and how long it's gone on for. So if we see a 15-year-old who has felt that they were the wrong gender since age 3, and they really feel they are sure that they are meant to be a different gender, and the fact that their body doesn't match what they feel on the outside is very distressing to them, those are all characteristics that add up to there's a good chance that person is going to have persistent gender dysphoria. That is not going to be a phase. Again, different for every kid, but those are things that you should think about if you are seeing kids who have intense gender dysphoria. If they are really basically upset about it, they feel like they're in the wrong body. It's gone on for a long time. It's been going on for a long time, for longer than you expect, maybe. And they're sure that they are meant to be another gender. Those are all clues that should tell you this isn't a kid that's going to necessarily change their mind. One thing I want to put in here is regardless of what we recommend to a child, to a family, the guidelines that we give, I don't think at any point we should be pushing. Now, I don't think we should be pushing generally in most of medicine, unless there's an emergency situation. But the whole point is when we want to respect a patient's autonomy, we give them the information they need to make their best decision. So we do shared decision making. So there's a lot of language out there politically or otherwise about, are we pushing this on children? And my 2 cents is we shouldn't be pushing it regardless. We should be letting the child tell us what they feel, and we should be informing them of their options, whatever those are, and then helping them to make the choice. So that's my 2 cents. I do think that by the time a child comes and they have all those factors potentially, so maybe they feel extreme gender dysphoria, it's been going on for a while, even if it hasn't been going on too long, but they feel it very strongly, they've done the research, they come to you and they want a letter, and this is usually for my psychiatry and psychology colleagues. We're the ones who tend to write the letters recommending treatment. If they come to you and they know everything about the letter, what it needs to say, what they need to transition, and they know they want to, generally speaking, those are the ones that are going to benefit the most from transitioning, if I'm being honest. So once it gets to that level, they are self-selecting that these are the kids that are going to not change their mind and will do well with referrals and follow-up treatment. So mental health and gender dysphoria, again, we could spend forever on it. If you take anything from this talk, I hope it's that you take these aspects, which are very shocking and upsetting, and it's hard to believe. I'll be honest, whenever I see this number, I always feel like, how is this possible? But transgender individuals experience a high degree of homelessness, violence, abuse, and hate crimes. And I mean, the numbers are quite high. I didn't put them on there, but they're high. However, the big thing that I keep in mind as a psychiatrist, transgender individuals have a suicide attempt rate of 41% that far surpasses the national average of 4.6%. That's a huge risk, huge. And they've shown we can mitigate that risk with, validating the patient's experience, having supportive language. So yes, it could be gender affirming care in the form of medical treatments that reduces that risk, but it can also be many other things. So the key thing here is it's not just an individual who's transgender, they're more likely to kill themselves. It's usually individuals who are transgender who feel such distress and are not getting help or support that's why that risk partially goes up. So again, if you take anything from it, that 41% I think is very important to know, because as medical professionals, we need to know, hey, this child is at high risk. One thing I also want to say is when you're looking up research, now, of course, it's always good to go to it's ironic I put a Wikipedia in the beginning of this, but it's always good to go to .org and to look at official sites that seem trustworthy, American Academy of Pediatrics, things like that. However, I do think it is good, especially in this climate with this being such a heated issue, to be aware of the other perspectives. My 2 cents with that is there are a lot of perspectives out there, even in medical journals, that are disguised as factual information. Now, it's good, I think, we have perspectives out there. So you can see here I have 2. Ironically, one's red and one's blue, just to make the point, but I didn't do that. So you can see here, delaying gender affirmation until adulthood is unethical. It's a pretty strong stance, right? Puberty blockers for gender dysphoric youth, a lack of sound science. That's also a fairly strong statement. And these are both in official journals. So it's important as you're reading these opinions, I think that's great, but also knowing that these opinions, that they're opinions, and to look at the original facts that they are basing their opinions on. I'm going to put some images from the Trevor Project up here. The Trevor Project is a leading not-for-profit group that looks at LGBTQ young people. It's also an advocacy group. They do have like an A+ rating for non-for-profits. They were endorsed by the White House for being a leading source on this during Obama's time. However, and I like their pictures and I think they do a good job. That being said, if you are dealing with a parent or family who maybe is, or anyone who is very against this topic, who feels that it is wrong or sinful, or, they are quite against it, I wouldn't necessarily lead with the stuff from the Trevor Project, only because those individuals might view this as propaganda, because it does have a perspective of wanting to support LGBTQ people. So even though I think that it is appropriate for me to share these facts on here, and they really do go back to correct data, at the same time, that's my warning. So what do we know about mental health? And there are many things we can look at. I'm just going to pop on a couple of statistics here. 56% of LGBTQ young people who want mental health care in the past were not able to get it. I'm sure that will change for better and worse in many states as our legislation gets more, not dramatic, but as we get some places that are promoting treatment and some places that are not promoting treatment. I'm sure this gap of the kind of care kids can get will really vary. Transgender and non-binary young people who reported that all the people they live with respect their pronouns, they reported lower rates of attempting suicide. That goes back to how can we lower that rate, that high rate of suicide attempts? And so I think it's important to know this is what the research shows. Fewer than 40% of LGBTQ young people found their home to be LGBTQ affirming, and roughly half of transgender and non-binary young people found their school to be gender affirming. Those who did reported lower rates of attempting suicide. Again, I am not here to force my thoughts, but this is what the research does show. One thing to know is that the younger individuals are who report gender dysphoria, the higher the risk of suicide. So, and I'm sure there are many reasons for that. But you can see here, transgender, non-binary people who came out before age 13 had increased odds of suicide risk. They also experience higher rates of victimization due to their gender. The ones who came out before 13 and had high family support reported lower rates of considering and attempting suicide in the past. Now, there's some more studies that I didn't show on here, but also the younger a child is that they come out, the more that the risk of suicide goes up. So I'm not trying to say, a child who's young and says that they are transgender, that there is anything good or bad about that. But we do have to keep in mind the younger they are, that they come out, the more likely the risk of suicide, again, for multiple reasons. Okay, so let's get into medical treatments. This is my overarching slide of medical treatments, but I do try and go a little bit more into the individual treatments in the next couple of slides. I will not spend time on them just because there's so many things that we can cover. So I had to choose which do I want to talk about, what do I not want to talk about. Medical treatments in general, though, this is my summary slide on medical treatment. So when we talk about the big ones, they're usually puberty blockers, hormone therapy after puberty, and surgical interventions. Now, of course, there are other things. There is electrolysis for hair removal that goes along with gender affirming care. I'm not talking about those. I'm talking about these are the big sort of 3 ones that come up in research and referrals and everything. The short answer is, are they safe? Yes. The interventions themselves are widely utilized, well known, and thought to be safe. Part of that reason is because all of the interventions are generally used and have been used for other things in medicine. So if we talk about top surgery, yes, top surgery may be a new thing, but mastectomies, which is essentially what top surgery is, have been around for a long time. We have people who are very skilled doing them and who do them day in and day out. So the actual individual treatments are pretty well established in medicine, but often for other indications. So what's the long answer? And even then, this is the short, long answer. Are they safe? Sort of. So it depends on what your patient thinks of as safe, and often comes down to the risks and the benefits of the intervention versus not getting the intervention. Now, is this a child who highly suicidal, has had suicide attempts, who feels horrible all the time? Maybe that, in contrast to starting hormones, that might weigh towards starting hormones is better safety wise than the risk of suicide for that child. Now, but for each child, of course, it's different. You always have to weigh the pros and the cons. So the other thing that we have to be honest about is that, yes, mastectomies have been around for a long time. They're doing them day in and out. There are surgeons that is what they do, right? However, the data for the indication, we don't have as much of that compared to other parts of medicine. So do we have research on mastectomies for breast cancer? Yes. Do we have research on mastectomies for gender affirming care? Much less so than breast cancer. So the long-term data, there's some of that, but there's a lack of it compared to other things for so many reasons. So that is the honest answer. Now, they found that for kids who do end up getting referred for these treatments, the statistic I found that is only up to 1%, they think probably less. Those are people that end up being unhappy with the fact that they got these treatments. So less than 1%. Now, of course, all these numbers are coming out because this is a new thing relative to other parts of medicine. This is being talked about a lot more than it was 100 years ago, being done a lot more than 100 years ago. So we know things, but again, it's based a lot on other stuff that we know, like mastectomies for breast cancer. Now, again, these are the three big ones. If you want my slides, you can see them on here. And again, they don't even have a ton of information, but basically they show that each individual one, for the studies they've done, show that on average, they are pretty safe for kids. Now, we always have to consider the risks and benefits. So if a kid gets hormonal therapy early, then yes, for the rest of their life, they are more at risk for the things that go along with those hormones. Is that going to decrease their bone mass? Will that increase their risk of a certain kind of cancer? So all of that stuff that goes along with, if this child is getting treatment for growth problems, for puberty suppression, because they have early puberty and they're going through 4. So let's say it's not a gender issue. They have early puberty. It's an endocrine separate issue. They might still get these treatments and they have to worry about those same risks. However, so that's important to keep in mind. These things have been done. We have the data. However, we just don't have the research on the indication of doing it for gender dysphoria compared to other things. For the most part, though, it comes out that it's usually generally worthwhile for quality of life. So if this keeps a child alive, then usually the risks and the benefits outweigh the risks in that situation. Just what the research is saying. Of course, there's mixed data sometimes out there that you can find because this is such a new thing that we're doing compared to other stuff in medicine. Longer term studies are slowly coming out. For the most part, they're still saying, yes, this is safe, and kids end up feeling so much better that it's worthwhile taking the risks for those kids. So that is my 2 cents, is that most people are happy with what they get, and it does reduce the risk of suicide. And the lack of long-term safety data, I like this quote from a kid. Now it's interesting because if you're a child who has experienced gender dysphoria for 3 months and it's very strong, then maybe jumping right into surgery isn't the right choice. Maybe we need more time to think about it. Maybe it is, but maybe it isn't. What about the 15-year-old who has felt that way, feels horrible, and has felt that way for the majority of their life? And that's all they know is misery that goes along with that. So this is a quote from a kid like that. It says here, as one young transgender boy described, I would rather live 10 years shorter, but live a happy life being myself, and 10 years longer and being unhappy my whole life. So it's easy to think, I mean, I'm 38, so I'm often like, they can get through their lives as kids. They're still growing, they don't know. But for a child who's lived that long feeling horrible, that is something you have to have empathy for. Like that's been their whole life for them, right? So, okay, let's get into the bioethical aspects a little bit. Now, the first thing I want to mention, I'm not going to read all of this to you, don't worry. These are just some ethical questions we have to think about. These are some questions that are provided to us by parents, by society. So can a child consent to care? Can a young child consent to care? Can a parent speak for how a child feels inside? If there's a high risk of suicide because of gender dysphoria, do providers have a responsibility to tell families all the facts? Or will that out the patient and make things worse? There's so many aspects to this. Are there cultural implications? What if this goes against a family's religion? How do we manage all of this? And unfortunately, maybe good for me, but unfortunately, I do not have answers to any of this. These are all things that we have to keep thinking about. The bioethical issues are a little bit more specific, though, because we tend to think of very specific principles when we're talking about bioethical principles. So how are we going to use the bioethical principles to talk to kids and families? The same way that we do about all things. So people that come in who potentially have an STD, who potentially, their child has cancer, all these sensitive topics that we have in medicine, all these things that we're doing day in and day out. It's easy to forget with all of the controversy, but individuals who have gender dysphoria, they're not unicorns. They are patients in medicine who have a diagnosable problem, and there are treatments. So it's important to keep that in mind. Like, medicine in our society generally identifies this as a real issue, and we treat it. Regardless of if some people believe that or not, that is the general zeitgeist of it. We accept that. So a couple of differences that we look at compared to other medical problems that make this a little bit different. This is a more sensitive topic because of the controversy, because of the cultural sensitivity that we need to apply, things like that. So it can be more of a sensitive topic. One thing that might make it different is that we will get a lot of information from the child that we may not share with the parent. Now, that goes into, are we even allowed to do that with all the laws going on? I'm not going to take a stance on that either way. But what I will say is a lot of this means finding out from the child without necessarily telling the parent everything. Now, in psychiatry, we're used to that because we don't want to break confidentiality. So there are lots of things we hear that we don't run to the parent and tell. Of course, in terms of safety, we do break that confidentiality. But so for psychiatrists, they're probably used to doing this to some degree. For other people who aren't in psychiatry, who only talk to the child and the parent together, this might be a little bit odder. If you have a kid who comes in with an ear infection, usually you're not going to take the child away, speak to them separately about what their ear infection is like, and then go to the parent and then see what their views are on treating ear infections with antibiotics, and then come together and then go over the pros and the cons of Augmentin. That generally is not what we do. And that comes into partially this next thing of, in psychiatry, especially with gender dysphoria, but even in psychiatry, we utilize something called explicit consent much more than implicit consent, which is sort of the norm in the rest of medicine. Explicit consent is done, of course, in surgeries. We go over the risks and the benefits. You have to sign a paper that says, you can die, things like that. However, most of medicine, if you go in and you get Augmentin for an ear infection, they're not going to sit you down and talk to you about the pros and the cons of treating versus not treating, how this may lead to antibiotic resistance in the rest of society. So that's going on in the doctor's head, but that's not going on for the patient. We usually don't talk about it. We might talk a little bit about side effects, but for the most part, we are not going to go into everything that might potentially happen. And that's because as a society, we've sort of agreed, hey, that's okay. Doctors know what they're doing in this situation. So much more of it is implicit. However, in this situation, we need to be much more explicit. So we need to talk about the pros and the cons, how dysphoric this child is and the risk of suicide versus the potential risks of treatment of any sort. The hard thing here is that having this long conversation on explicit consent doesn't lend itself to a 15-minute visit. So my PCP friends and people with short appointments, this is a hard topic to get to when you're in a brief appointment. We're going to go into the bioethical principles. Now, there are lots of ways to approach bioethics, but one of the main ways we look at bioethics are these 4 principles. So we had 2 philosophers who sort of married philosophy and ethics and medical stuff together, and they came up with these are the 4 main ethical principles. So I'm just going off of that. The idea is these principles, it's always a balancing act. How much are we weighing doing what's right for the patient? Doing what's good versus what might hurt them versus justice versus autonomy. So when I tell a patient who maybe they're anxious and let's go talk about depression. They're anxious, they're depressed. And I recommend, hey, okay, let's try Zoloft. And I say, all right, let's just try Zoloft. I might be acting within the beneficence aspect. I'm doing what's best. But let's say I don't give them any of the stats. I don't do the pros, the cons, the risks, the benefits, then I may not be respecting their autonomy because they might not have informed consent. They're just going, okay, the doctor told me to do it. So we're always weighing these things. And with these, a lot of times there's no right or wrong answer, but they are things that we have to keep in mind. And I'm going to break down this issue based on some of the principles in that aspect. So how can we take a look at autonomy in this topic? So autonomy means shared decision-making. It means it can mean lots of things, but it means respecting the patient's wishes. So let's say let's talk about ADHD. I have a kid who I think would do great on a stimulant, and that's what research says is first line. I have parents who are terrified of stimulants because they've heard all the bad things. They have a friend whose kid went crazy on a stimulant and they don't want to do it. So I go over the risks, the benefits, and then I might go over the risks and the benefits of, say, guanfacine. And I say, this is second line, but it does work for some kids. That family who is informed, who understands, they can tell me, hey, we want to start with the stimulant versus we want to start with the guanfacine. I am giving them the information to help them make the decision. Let's say they come and they go, well, I want to do Xanax for ADHD. I'm going to go, no, I'm not doing shared decision-making with that because that's not an appropriate thing for me to prescribe. So shared decision-making is always the doctor brings the expertise and the patient or the family, they bring their knowledge of their own bodies, right? And we want to respect that. So things to keep in mind is how to let them have informed consent. So we should not be, a lot of times I think people in this field are worried like, oh, we're going to make the decision for the patient and we're going to make the wrong decision. We're going to, in gender, but in everything else, like I'm going to put them on this and that was the wrong choice. What do I do? And oftentimes I have to remind myself, hey, I can give the patient the choice within reason. I can tell them, do we start too high on a dose and maybe you get side effects, but it might be more helpful? Or do you start too low on a dose and it might still be helpful, but it might be less effective and you might get fewer side effects? That's a conversation I have almost every single day with patients because they usually know which one they want. Some of them just say, do what you want, but that lets them be part of it. So we got to do the same thing when it comes to gender. We tell them the diagnosis of gender dysphoria. We tell them the fact that developmentally children can be aware of their own gender by age 3. My dad called me at one point a long time ago, and he is a veterinarian. He had a client and he was like, hey, my client's kid is 8 and they said they're in the wrong body and they're sure they're a boy. He's like, can that even happen at that young of an age? And I was like, technically, yeah. If we believe that kids know their gender at a young age, it can happen at that age. Now, I'm not recommending anything. I hadn't seen that patient, but can it happen theoretically? Yes. So we do tell families that can a child know that they're the wrong gender? Yeah, they can. Is it always going to stay that way? Not necessarily. It depends. Every child is different, and we're going to treat the child in front of us. Just like one kid who comes in with a cellulitis that is not that bad, maybe it can be managed with a topical antibiotic or something. They come in with a cellulitis and their limb is about to fall off. We're going to treat that a lot differently. So again, in this situation, we have to look at the kid in front of us. But we have to provide them the information. If I see a kid who comes in and they are 18 and they've attempted suicide 10 times because they feel like they're in the wrong body, I will tell the parents and the patient, hey, this is associated with higher suicide risk, and maybe gender affirming care might be a mitigating factor that we can do to reduce the risk. I might also say, but at the same time, the law doesn't allow that here. So I'm not here making the rules. I am here telling them the information so they can make their decisions. So we go over all the stuff that I just let you know. So, treatments, are they safe or not? There are, of course, in each aspect. So for hormones, for surgery, there are medical guidelines. And so even if I refer a patient for surgery, in my mind, that doesn't mean I am doing the surgery. I can just tell them what, from the mental health perspective, what the risks and benefits are. The person doing the surgery also has to go over from their standpoint. So know your role and go over consent, essentially. Make referrals when the patient is ready. So you don't say, oh, you felt this way for forever, you feel horrible, but I think it might be a phase. So I'm not going to make the referral. In this case, that would be not protecting their autonomy, because even if you don't agree, if it's within the normal bounds for you to make a referral, then you have to say, okay, maybe we will give it a try and we will see. I'm not saying if you see a child that looks like the wrong gender to you, that you automatically make a referral. These are not jump decisions, but you have to go with the medical evidence and allow the family to have an opinion. Okay, when we talk about beneficence, what are some things we can do? Offer a validating environment. That can be anything from, having signs up in the room to just listening non-judgmentally. The reason this is beneficence, which is acting in the patient's best interest, is because of that high rate of suicide. We have to be mitigating those factors when we can, and doing the simple things can actually mitigate the factors. So if we can use preferred pronouns, then that can lower the risk. Again, I'm not coming here and saying the law says it's okay versus not okay. I'm just telling you this is what can mitigate the risk. That's all. We can listen non-judgmentally, and that can make a person feel heard. So we're not necessarily we don't have to do gender affirming care. If we do good medical care where we can listen and use empathy, that can be helpful. So, and for these individuals specifically, because they have felt so marginalized, because they have felt so different, because they feel so hopeless, listening and having empathy without jumping to a conclusion, that can lower that suicide risk, which I think is amazing. So those are things that we can do that are good. Okay, now we're talking about first, do no harm, the classic one that people know with medicine. What I put on here is I said, don't insist on using like dead names or birth given names. Now, of course, if the law says you can't call someone a different name, I suppose that's very hard. In my mind, calling people what they want to be called is not just a gender issue. It's a boundary issue. If I tell people this is my nickname, this is what I personally prefer to be called Burgundy over Mrs. Johnson, personally, even if regardless of Dr. Johnson, because I don't like the feeling of being associated that I'm like my husband's territory. I don't know. It's just my thing. I would rather someone call my first name, and I find that less insulting than Mrs. Johnson, even in a doctor role. But that's me. I have set that boundary. So here, it's especially important if someone sets a boundary for what they like to be called, try and do it. If you accidentally do the wrong thing, you call them the wrong gender, the wrong pronoun, apologize, mean it, like you would in any other situation. If someone accidentally on the phone said, okay, thanks, sir. And I was like, actually, I'm a lady. They go, oh my gosh, I'm so sorry, right? It doesn't matter, regardless of if I have gender dysphoria or not. But even for these people, it's especially important because that is one less invalidating experience. If you're going to talk about gender, talk about it helpfully and not hurtfully. That maybe also sounds obvious. I had a patient who said that they had a teacher who, talking to them in front of all the other kids said, you don't have a traditional male voice, so can you like sing differently? And that kid was one who identified as being male. They were at birth, they were assigned female. And so for them, that was really invalidating because that teacher didn't need to talk about gender in front of everyone like that. Again, if you need to put it in the notes, you need to do things. Of course, I understand when it's necessary. If we're doing a certain kind of surgery on ovaries, maybe we do have to mention that the patient has ovaries, but we don't necessarily have to talk about that in a regular psych note at a follow-up. Be careful of what you put in your documentation. So I like to ask, what do you like in your note? And I'm not saying to be improper. I'm not saying to write things that are medically illegal or unethical. If you have to write it in there because you have to write it in there for medical purposes, do it. But if you don't need to, don't. So let's say there's a patient who's questioning and they've told you they're questioning their gender, and they're thinking about, and with their friends, their peers, they like to go by a different name. Right. But they haven't told their parents. They're not comfortable with that. They don't want that. Maybe they're just exploring. They don't want to open up a can of worms, or they feel their family will be invalidating, or they're private, whatever. And I say, okay, well, so you identify as male with your friends. What do you want me to call you in front of your parents? What do you want me to refer to you as in the note? And I have one right now I just spoke with recently who was like, call me she, her, use my assigned birth name in front of my parents. And if you want to use the other terms with just me personally, that would be nice. But also, I don't weighs the potential risks. So just keep that in mind. So you don't want to write transgender all over their note when their parent can see the note and they don't know. Okay, let's see. Now, justice. Oh, this is a hard one because this is really when we get into the medical legal stuff, but I'm not going to go into that. I'm not going to look into the system's justice. I'm going to look into individual patient care justice. So all patients are equally entitled to a fair distribution of healthcare resources. That's what we would say under the principle of justice, right? Now, individuals with who identify as transgender, have gender dysphoria, they have shown they're less likely to have health insurance that will cover things, to have health insurance. There are all these legal barriers. What we can do is we can refer when possible. We can be willing to talk to insurance companies when we disagree with maybe what insurance is doing, the things that we would do for any patient in any situation. So you also have to ask, how are you going to approach laws that prevent gender affirming care? So many organizations have come out, the American Medical Association that says gender affirming care should be a right, that they believe in it. And then you have laws in those states who are saying that, we're going to outlaw all things that are transgender. So you have to decide, are you going to take a stance? What stance are you going to take? And what are you going to do to help those patients? So one thing I think you can do is when you're talking to the family, going into the next part, talking to the family. I promise I won't take a ton longer. This is sort of the faster part. Maybe it shouldn't be, but so let's say you have a family that comes in, the child has identified that they have gender dysphoria to you. The family knows, they're okay with it, but they're kind of like new to the process. I have a lot of parents like this that are like, I don't know what to do about this. You can coach them on what to ask, and you can role model by asking certain questions and being interested. I'm not saying to out the child and ask all these questions as a role model and then have a parent never come back to you because they think that you're putting ideas in the child's mind, and then they're going to go home and invalidate the child more. What I'm saying is, if the patient's okay with this, you can role model some of these kinds of questions in front of the parent. The nice thing about these questions, it is from a blog. Again, I used a Wikipedia and a blog to cite things here. But what you want to do at the end of the day is be curious. So when we ask questions about people who have gender dysphoria, we want to be curious and use empathy. We want to know about their experience. So I have a list of questions here. These are questions that parents can ask kids. These are questions that professionals can ask kids. So even though this is written towards parents, I think this still works. You as a doctor, you want to know things, you can ask them these things too. I asked the majority of these questions during gender dysphoria evaluations, but not all of them. So it just depends on the kid. It depends on what you want to ask, but be interested in their experience is the big point. Understand that, how do you can say a kid has gender dysphoria and you go, and, I know there's a law about not having that you can't use the same bathroom in this state. How do you feel about that? What bathroom would you like to use? So we're not pushing anything. We are simply learning. But this can be validating, right? Some things for when you're working with parents who are also like, they're kind of okay with it, but they're not sure, they're questioning, is again, same medical stuff. You're going to be a good listener, show curiosity. These are things that you want to role model because this is what you want the parents to do with the kids. You want to tell parents, hey, I want you to be curious about your own kid. You may not know all the right answers to this. This is new territory for you, for me. But you know what? We're going to try and find out what this kid feels and what works for them. It can be as simple as that. So I tell parents, try and listen to what the kid wants. See what they have to say. You don't have to have an opinion. You don't have to have advice. In this situation, you can just listen. I do tell parents, if they're really conflicted and they want to figure it out, that they can always seek out a therapist. There are support groups because some parents, they do go through grief. They feel like their child is not the same child that they gave birth to when they have a different gender. And they don't want to put that on the kid. So they want to do their own work, but they also have to admit that that's a problem for them. And you know what? I think that's great if they can do that, as opposed to telling the child, you're wrong, I'm right. Maybe they can go, I need to figure out how I feel about this first. And there are support groups, there are books, there are things they can look up. What about when the family's not accepting? Oh, this is the big one, right? That this is hard. We can start with small steps. They can still make the difference to the patient that you're working with. So I always want you to remember, support is a spectrum. Lack of parent support is painful for kids, but there's a whole spectrum of support. The parent who uses the patient's preferred name but isn't comfortable with surgery is different than the parent who says they refuse trans care altogether. So just keep that in mind. It's not all or nothing. We're all in our own learning processes as professionals, as parents, families, the kids. You can help role model and shape things without arguing with a parent. So you can listen non-judgmentally. Those may seem like obvious, but they can quite literally mitigate the suicide risk and help the child. So doing what would be very thoughtful, good medicine can really be what's helpful. Again, this is why I'm not probably teaching you anything new, so that's hard for me, but it's also being very mindful about that this can make a big difference. Something to keep in mind, we're communicating with people the moment they step into our offices, sometimes earlier. What are we making clear is important for them to know about their children? So you see this hallway, this looks pretty freaky in this picture. To me, this communicates maybe cleanliness, I don't know, bare walls, but this isn't the place where I'm going, oh, look, this place is so happy to have me. And they have pictures up saying, hey, here's you can ask this person for anything. You get feelings of when you walk into places, and we can help provide more validating environments for kids and families. When I go to my pediatrician's office, this is usually the kind of stuff I see on their walls. Not saying it's bad. Of course, it's great. They should help me with knowing screen time, what's good for my kid to eat. But is there a way that we can add more information, that we can choose to share more information? And there can be a spectrum of this as well. It can be, do we want to put up signs about LGBTQ students? Do we want to maybe we want to talk about how this is a safe place. We want to make sure kids know that they can bring things up, even if their families don't. Maybe we want to do something as small, but still helpful, like telling parents how to look for trusted sources online. That's something we could provide on our wall, saying, hey, if you hear these things, these are some websites you can go to, or make sure to check, these are high quality websites. So there's a whole spectrum of how we can provide support. Use empathy when you're talking to parents and to kids. So you can help these kids, even if their parents are not agreeable, or they're not ready to talk, or they're totally against it. Think of times where you have gone through similar experiences and how it made you feel. So if you didn't have information on something and you feel lost and you feel stuck, you don't know what to do, and someone gives you that information you need, think about how relieving that can be. You can do that for kids by giving them information on gender dysphoria. Hey, this is not you just feeling horrible your whole life. This is a real diagnosis. This is something we accept, and there are treatments. What about times when you maybe felt uncomfortable in a situation and you were scared to bring stuff up, and someone invited you to be able to, gave you permission to be okay with those feelings? You know, the doctor that says, you know, this is a really hard time for a parent when their kid's going through this. I want you to know that that's a thing. A lot of times when I say that during my appointments, the parents start crying because deep inside, they're so scared about what's happening with their child. You can do that for parents, for kids, by just saying, by acknowledging like, hey, you know what? It's going to be okay. I realize I want to make you feel comfortable. What can I do for you? We do have to weigh some of the bigger issues. And one of the biggest issues I think of as a child psychiatrist is that suicide rate. So there are certainly many issues we can talk about. For me as a child psychiatrist, suicide, that 41% suicide attempt rate is big. Every once in a while when I talk to a parent, and I don't usually say this, but sometimes the way I really do, I come out of it as, you can choose if you want to, you know, call your child by their assigned birth name, or you can see if you want a dead child. Again, that is very blunt. I'm not trying to come out and say that I say that, but sometimes reframing the real grittiness of the issues for parents, especially when the situation's appropriate. When I see a kid on the unit, they've tried to kill themselves 10 times because of gender dysphoria, and the parent is really struggling, I might say, hey, the evidence says if we want to reduce suicide risk, this is one big thing we can do. And you have to weigh the suicide risk versus the names you want to use, the, you know, what's going to help, you know, help the child that you don't necessarily believe in. It's not a black or white issue. It's not just do this. It's, we have to really look at what's going to be the best bad option if that's how the parents see it. So again, key points, just to summarize, we went over all of this. Talk to the kids separately if you can. Be accepting, validating, don't out patients. Tell the families the information so they're informed. Refer the patient when the patient is ready to what you can refer to. Learn. If you don't know stuff, just keep learning. There are guidelines, there are resources, and we can't change the laws always. You can try, but we can also, as medical professionals, it's our job to know. I mean, like if I'm a pediatrician and someone comes to me with an ear infection and I go, I don't know, I don't treat ear infections. I don't know. That is a harder situation than the pediatrician who maybe just started their residency and they're like, oh, I have to go look up which to start with. So being able to look up things and learn things. These are some quotes that I liked. And just for time's sake, we're going to look at the bottom. Gender affirming care for transgender youth is essential and can be life-saving. So that is true. It can be life-saving. Of course, we have to weigh it with all of the problems going on. We have to weigh it. How likely is this child to hurt themselves versus how much do I say, let's wait and see. There are still kids that are exploring out there, and we don't need to make recommendations. We can just see how they feel. So, all right, 5 minutes left on this huge controversial topic. I'm kind of glad it's not longer because then I don't have to field all the complicated questions. But I'm done now.
All right. Well, thank you, Dr. Johnson. We have time to take a couple questions, so please feel free to type your question in the Q&A, and we'll see if we can get a couple answered.
Did I stop sharing?
I'm sorry?
Did I stop sharing?
Yeah. Yes,
okay, good.
You did.
Just check.
Okay, let's start off with a question maybe that came in through the registration. I have concerns regarding mental health conditions and how to discern transient general dysphoria from gender dysphoria.
Yeah, that's an interesting question. So again, this does not lend itself to a 15-minute appointment, but you have to ask a lot of questions. So for me, it comes down to what are they dysphoric about? That may seem obvious. The thing is, people with gender dysphoria, they can have major depressive disorder, anxiety, just like anyone else, and they are more at risk of having other disorders. Whenever you have one disorder, you're more at risk for having other disorders. So for me, the key is knowing is saying when someone is depressed, like let's say they don't want to go to school, I try and investigate why. Okay, why don't you want to go to school? Because I'm too tired to go to school. That might be more depression. I don't want to go to school because I feel weird feeling different and I feel like people are going to look at me different and I don't feel right. That might be more gender dysphoria. So you do have to pick apart what is causing them to feel bad. If they say, I don't want to go to school because I'm being bullied because I look different, then I would say to them, for example, well, then, do you feel like if you did get treatment, if you did not, like if you looked the way that you wanted to look, would that make you feel better regardless of the bullying? People can still bully you for any reason. And if they said yes, then that would lead me more towards gender dysphoria. That being said, it's helpful to go through all those criteria. If you're not sure, go through the major depressive disorder criteria, go through the gender identity disorder criteria. Let's say they have both. You want to look at how much are they just suicidal because they are depressed and don't want to live because they just are negativistic, they hate life, they have sort of general melancholic things, versus the deeper you go, is it more, I don't want to live because I feel like I'm in the wrong body and I feel like no one understands me. So you do have to dig a little bit more in those situations. I don't know if that answers it for people, but yeah, good question.
All right, thank you.
Mhm.
And then there was a question about, are there some preferred books or other resources that you would recommend for providers to give to families?
That's hard. Now, when they, so this is very much, my caveat here is that I give information to families when they're ready to get it. If I have a family who's fully against it, I start by just telling them some of the stats myself. And then I say, do you want to know more? Is this a situation where you want to learn more about it? And then the CDC is a good place to start. So the CDC is very well, respected by people. And so, yeah, you could send them to the American Academy of Pediatrics, American Medical Association, but I think the CDC is a good all-around one because they have statistics on there and you can type in like CDC transgender and it's not very pushy either way. So for a parent where you're not quite sure where they're at, maybe that one. For a parent who wants to know more, who's like, hey, I want to know more about this. Is there a book I can read because I'm really interested? They do have some gender dysphoria books for parents on Amazon that I can send out. There are a couple really good ones. But I would start with the CDC in general, just if you don't know what you're getting.
All right, thank you so much.
Yeah.
Well, we did have a couple other questions, but I can send those to you and maybe we can get a response out to those folks.
Sure.
I'll do a few announcements for closing the session today. This course was certified for AMA PRA Category 1 credit. Attendees are eligible to claim a continuing education certificate by completing the evaluation and downloading the certificate of participation. The step-by-step instructions on how to claim credit are included in the chat, and I'll also be sending this as an attachment with the follow-up email. But if you do have any questions, please feel free to reach out to me. My email is kafi, K-A-F-I, -Dixon, D-I-X-O-N, @uiowa.edu. So in closing, I just want to thank Dr. Johnson for presenting today on this very important topic, and I appreciate everyone attending today. Have a great afternoon.
Thank you. Thanks, guys. You too.